oral presentation. For the next oral presentation entitled Rapid Renal Evaluation Utilizing Microalbumin to Creatinine Ratio in Spot Urine for Immediate Assessment of Serum Creatinine in Emergency Care, presented by Kamonlak Khwansoo from Medical Education Center, Maharat Nakhon Ratchasima Hospital.
My name is Kamonlak Khwansoo from Maharat Hospital. Today I would like to present research rapid renal evaluation utilizing microalbumin to creatinine ratio in spot urine for immediate assessment of serum creatinine in emergency care. Due to caring for patients in the emergency department often require urgent CT scan, which usually involve giving contrast media. One of the most common complications after receive contrast is contrast-induced nephropathy or CAN. According to Critical, the incidence of CAN is about 1 to 2% in patients with normal kidney function. However, in patients who already have chronic kidney function disease, the incidence can rise to 22 to 25%. Therefore, assessing kidney function before giving contrast media is important. However, waiting for a serum creatinine result from the laboratory can take 1 to 2 hours, which may delay diagnosis and treatment. This leads to the idea that we should have a point of care to assess kidney function more quickly without waiting for the lab. From this concept came the interest in using urine dipstick testing to estimate serum creatinine level as a quick bedside assessment of kidney function. Urine dipstick testing is fast, take about 5 minutes, and non-invasive. That could help reduce waiting time and improve patient safety in the emergency setting. The primary objective of this study is to evaluate the correlation between microalbumin to creatinine ratio from the urine dipstick and serum creatinine level in patients in the resuscitation room of emergency department. We designed this as an instrument-oriented prospective cohort study conducted from October to December 2024. Our sample include 100 patients who present to the emergency department of Maharat Nakhon Ratchasima Hospital and met the inclusion and exclusion criteria. We screened patients over 18 years old in the emergency department who had a serum creatinine result and were able to provide a urine sample. Patients were then categorized into the 3 serum creatinine groups. Importantly, the team responsible for grouping patients by creatinine level and the team performing the urine dipstick test were separate to minimize interpretation bias. And finally, we compare the dipstick result and serum creatinine level to evaluate with reliability reflect kidney function across the 3 groups. This is image show that the device used for testing the Cybo 2AC urine dipstick. Each dipstick contains 2 color pads. One indicate microalbumin and one indicate creatinine. The color are compared to the reference chart on the container to determine urine microalbumin and creatinine level. Okay. And this is the result. A total of 100 patients were enrolled with a mean age of 62 years, and about 68% were under 60. The sex distribution was roughly equal, and the most common chief complaint was dyspnea, followed by abdominal pain and vomiting. And this is a table compare dipstick microalbumin to creatinine ratio result with serum creatinine level. This shows the serum creatinine more than 2 mg per deciliter. 24 of 32 patients have a high abnormal dipstick result showing reasonable ability to detect severe renal impairment, and serum creatinine below 1.2 mg per deciliter. 11 patients were correctly identified as normal, but 25 were labeled abnormal or high abnormal. And the kappa is 0.496. This is moderate agreement. and this is sensitivity, specificity, and NPV, PPV were collected at a table. And this suggests that a normal dipstick result reliably rule out renal impairment where abnormal results require laboratory. This is my discussion. Our analysis of 100 patients show that the SIBO urine dipstick perform well in identifying severe renal impairment. In the patient with serum creatinine more than 2 mg per deciliter, the dipstick demonstrates good sensitivity and good NPV, suggest that it can help screen high-risk case. For those with creatinine below 1.2, the specificity was high and at 83% indicate good ability to rule out kidney dysfunction. However, the performing dropped in the intermediate group with sensitivity only 25%, emphasizing the need of confirmatory lab result. This is limitation of the research. The test strip is semi-quantitative and may be affected by dehydrated or dilute urine, and the sample size is limited. The study conduct is in a single hospital. There may be bias from the local healthcare system and no comparison with EGFR and not possible to conclude the trend of kidney function in the detail. And the conclusion, this study showed that urine dipstick test can serve as a point of care screen tool to help rapidly identify patients with rarely normal kidney function. However, when the dipstick result is abnormal or high abnormal, laboratory confirmation is still necessary. Thank you.
Thank you for your inspiring talk. Do you have any comments or any questions?
Since you mentioned that they already have a systematic review of this data, and my question is, why do we need this study again?
We use another different. This device is not has done before, and it is different from another research.
What is your hypothesis, and how do you calculate the sample size of this study?
Sample size. First, we think this is pilot, and this is first we compare with this is a pilot study, and
You can speak in Thai if
Thank
I can
you.
translate later.
ค่ะก็คือก่อนหน้าก็คือเป็น pilot study ค่ะตอนแรกเป็นคำนวณแล้วจะได้ประมาณ96คนค่ะคำนวณจะใช้แต่ว่าเพราะว่าเป็น pilot study ก็เลยกำหนดว่าเป็น100คนไปเลยค่ะ
So you did not use the correlation as a method to calculate the sample size. You just want the pilot study and you make the sample size of just 100 people, right?
เป็นตอนแรกเป็นเปรียบเทียบเป็น2คูณ2ค่ะก็คือเป็นการเปรียบเทียบระหว่างกลุ่ม2กลุ่มแล้วจะได้คำนวณได้เป็น96คนค่ะแต่ว่าเพราะว่าเพื่อที่จะได้มีพอไปเก็บข้อมูลแล้วมันได้100คนก็เลยเอา100คนไปเลยค่ะ
So since the study reviewed that the kappa 0.496 which is a moderate agreement, would you recommend to use this test in the outpatient clinic?
เหมือนที่สรุปตอนท้ายค่ะก็คือตัวนี้ค่ะสามารถในสกรีนในคนที่มีเป็น normal kidney function ได้ค่ะก็คือแต่ว่าในกรณีที่เป็น แลบที่เริ่ม abnormal ขึ้นไปอะค่ะก็จะมีผลที่ไม่ได้ถูกต้อง 100% นะคะตรงนี้ก็คืออาจจะเป็นข้อจำกัดในการใช้ แต่ว่าในกรณีที่มันเร่งรีบโดยที่ประเมินสามารถถ้ามันประเมินได้ก็คิดว่ามันน่าจะดีกว่าการไม่ประเมินอะไรเลยอะค่ะ
Okay. I am radiologist. And then I think for the aim of this project, I think you need to keep the time for the further investigation, especially the CT scan. But if the patient have the worst of renal function, and then the accuracy of the test is not good, it have the worst effect to the patient. If the kappa score is good, it's a good agreement. I agree with you, it have the benefit for the patient in the emergency room. But the kappa is the 0.4. I am the radiologist, and I need the serum creatinine or EGFR. Okay. And in the one issue is this study you to show is a prospective cohort study, but I don't think so, because this is the accuracy test. This is the diagnostic accuracy test. Okay. Thank you.